Please join us in welcoming Dr. Randall Brand for his talk on the genetics of pancreatic cancer.
Well, thank you. I appreciate it. For those of you that I know, hello. I always try for patient confidentiality. Let you come up to me. I, of course, don't just acknowledge you pleasantly, but I'm thrilled to hear and see that so many people are doing well. But as you know, I'm still employed, and my goal is, as I was telling Mike, is I just want to become a heartburn doctor and just give people Prilosec all day long and get rid of my pancreatic cancer practice. So I'm happy to do that, or just counsel people. That would be the best way of trying to avoid it. So unfortunately, I'm still employed. So today I'm going to talk about a few things, but this is just to remind us, and I think many of you are unfortunately are touched with the disease, that it affects people. And I'm cognizant of that when I give my talk here, that this has a lot of ramifications for the things that I say, because I've been very lucky. Many of you have participated in some of our research studies, for our pager study that get approached at a variety of things, for our pancreatic cancer registry, where we're trying to understand the disease, and it's really expanded. We share the resources with many other institutions across the country. And it just shows me a time that's so stressful when people are being worked up for a cancer, that, you know, the vast majority of our patients spend the time to do it, not because it's going to help them, but it's going to help others. And so really, it's only because of you and the people that I can even be up here and tell you about these advances. So thank you all for those of you that have participated. So today I'm going to give a little bit of background of pancreatic cancer, just briefly. Then give you a little bit, not knowing what everyone's background is in genetics. I'll give a little bit of genetics. We're not going to start with the fruit fly or anything, but we'll go a little bit more quickly. Then I'm going to just briefly review how pancreatic cancer develops, just to show you some of the nuances, because I have to be honest up here when I talk about these things, that we don't know everything. And we don't know if some of the things that we do make a difference. And so I don't want people rushing to do things when it may not be the right answer. And some of the things that I say now in 2015 are quite different than what I said in 2005 when I gave these lectures. So we know it's a constant changing field. And then a little bit of background on cancer screening, because many of you are motivated to hear this talk, because it's not just worrying about yourself, but worrying about your family members. And that's, of course, an instant reflex. And then what is our goal of pancreatic cancer screening? Who should be screened for pancreatic cancer? And then our approach to genetic risk assessment. I don't use the term testing, because we assess you. And we give you the probabilities, we tell you the pluses and the minuses, and then it's a joint decision. So that's what's involved in our program. So it's nothing that forces anyone into a decision they don't feel comfortable with. And then how should pancreatic cancer be screened? So remember, just generally speaking, cancer is common. 1 in 3 people will develop cancer in their lifetime. And there's about a 1.4% lifetime risk in the United States for developing pancreatic cancer. So that translates into about 1 in 71 people. I couldn't find it, but I think it even flashed down a little more lately to 1 in 69. But I can't swear to that it may be up to 1.6%. I tried to look again in the cancer statistics when I was updating the slides for 2015 and could not find that statement. So in the U.S., we're going to have almost 49,000 cases diagnosed. It's unfortunately become the 3rd leading cause of cancer death-related mortality in the United States. So the good news is some of these other cancers are doing better. The bad news is that we still have a lot of work to go on pancreatic cancer. And I think that everyone in this room is aware that there's a lot of institutions, including the one I'm working with, trying to get better. That the status quo is not acceptable. And so I think by participating in this, we're actually seeing edges. It may be a minor increment, but I saw this year it went from 6% to 7% overall 5-year survival. That's, you know, almost a 20% improvement. That's good. That's good. Those are the right steps. And hopefully, as we learn more about the tumors and can identify who should be screened for it, we'll do better. Always have to make the plug, as you'll see. I hate smoking. And, you know, it's a controllable risk factor. So please, if you have people that you know that smoke. You get pancreatic cancer at an earlier age of onset, and it doubles or triples your risk. And if you have family members who have pancreatic cancer, their risk is already slightly increased to begin with. You don't want to magnify that risk even more. But the greatest risk factors that we know of today are related to inherited factors. So this is the pancreas. It's located in a terrible location in the middle of your abdomen. We can't feel it, can't easily see it, and it develops symptoms. By the time it develops symptoms, it's usually grown so that it's been very, very challenging to treat. I should just point out that, of course, this is the bile duct. And since about 50-60% of the cancers develop in the head of the pancreas, often many people have had to deal with turning yellow, jaundice. And that's because the bile duct courses through and meets the main pancreatic duct. Remember, the pancreas serves a couple major purposes. One of them, to make insulin and other hormones to regulate your blood sugar and a few other gut regulatory type of functions. The other is to make enzymes to help you digest your food. So that's why many of you you've been treated or maybe put on pancreatic enzymes. And so when you eat, the bile helps you absorb fat. The bile comes through the bile duct. The pancreatic enzymes come through here, and they mix in your first part of your small intestine, your duodenum. And so that's why we use that location to do things like ERCPs and everything that we get to with the endoscope and through that opening there. It also enables us to do endoscopic ultrasound because we can position the scope in different areas of your intestine and see the pancreas. And so this is just a CT scan showing a dilated pancreatic duct, and there's the mass. You could see all these different organs, the liver over here, the kidney over here, your stomach over here. It really is right in the middle. Hard to see. So what is genetics? That's the branch of biology that studies heredity and variation in organisms. And we grossly describe it as how traits are passed down through families and why they're different from each other. So we all have chromosomes. There's a total of 23 pairs. Now, one of those pairs is the sex hormone, so they aren't always exactly identical. They aren't. An X and a Y chromosome for males and 2 X's. And then there's 22 pairs that are the same for everyone. Now, each chromosome contains many genes, and these genes are made up of DNA. And so the genes determine through developmental factors and being made into proteins and other factors what we look like, what's going to happen to us in many instances. And so each of these are coded, these genes, by nucleotides. And if there's a mistake in the coding, that's called a mutation. And so most of the mutations that you hear about talking about in the press, this tumor, this drug works well for this mutation, those are mutations that you weren't born with. Those are mutations that your body, your cells in your body, separate from the original cells, developed. They weren't what we call germline mutations that you were born with. And that's why things like smoking increases the risk of getting those mutations in these cells, and is one of the factors that leads to developing cancer. But you can inherit mutations, and we all have variations. It's become cheaper to do the whole genome and look at all the different nucleotides. I mean, it took the NIH many years and billions of dollars to do it, and now you can do a whole genome assay for under $5,000, and in all practical purposes, you could do it for $3,000. And we know everyone has variations, and so that complicates the matter because everyone says, why don't you just sequence all of my genes? We don't know the function of a lot of these variations, and they may have no significance or no risk, and most of them don't. And so you'll hear the term variants of unknown significance, and that's what we're alluding to. Some of them, though, we do know will impact on the function. So we get one copy from mom, one copy from dad, and they're passed down through the families that way. And so when the condition's called autosomal dominant, you only need one copy of that mutation or a problem in that gene for you to express a risk for it. Doesn't necessarily mean that you're always going to develop, if it's a cancer risk, cancer with it, but your risk is greater. And if it's autosomal dominant, then we know that there's just need one copy. And so when we do genetic testing, since you only need one copy, that means that you only have a 50-50 chance of passing that on. And your siblings only have a 50-50 chance of carrying it. And that's because if you look here, you know, the affected dad, and this is the mutation, is that open white square, that you get, you know, he's passing on to two of them here, but he has a 50% chance of passing either the good gene or the bad gene. And then mom, it's not an issue. Conversely, an autosomal recessive gene means that you have to carry two copies. So mom and dad both have to give it to you. The classic disease for this is cystic fibrosis, where it's a common condition, actually 1 in 20 carrier rate. And, you know, so it's, but you need a copy from both mom and dad to have the full-blown cystic fibrosis. So that means your children only have a 1 in 4 chance of carrying the gene. And it's just probability here, which we'll sort of skip, but they have to get two affected ones. And, you know, 50% chance of carrying one affected gene and being a carrier themselves, and then there's a 25% chance that they won't carry the gene at all. And then where most of pancreatic cancer falls, and most of our complex cancer or cardiac or diseases in general, is multifactorial with environmental influences. So these genes don't necessarily give a risk that's 80% or 100% of carrying it. It may just be double your risk of getting cancer. So 1.4 to 2.8% risk, similar to what smoking is. And then if you smoke maybe with that gene, your risk may go up to 5% or 8%. And it's just making its probability, and you get the bad luck of being in that 5 to 10%. And you have another gene that may add a little bit here. And then all of a sudden, all the things are in a bad situation, and you got unlucky, and it goes on to cancer. And that's probably the way, simplistically, the majority of cancers occur. So this is complicated. I have to admit, I don't have the time to sit through there and sit with the patients, but you know, we have very experienced, and I'm a strong believer, and several insurance companies have become a strong believer in that, requiring genetic counseling to determine, one, the appropriate testing. And for some of my patients that have come in here, it turns out that they don't have cancer, but a living relative does. They know my philosophy. Let's try to get that information from the most informative person, which is a person with cancer. And so they'll verify it. And I didn't show the slides here, but there is a big, problems with how we report cancer. Someone gets pancreatic cancer, and all of a sudden someone else had a cancer in their abdomen, it becomes pancreas. When it turns out it could have been colon. Sometimes they think it was cancer because they had their colon removed, so it must have been cancer when it was removed for a totally benign condition. So the genetic counselors, to the best of their ability, try to become detectives and help sort this out, because it's not common to a given individual, it's common to the field, and we're not talking 5 to 10%. We're talking that 30, 40, 50% of people will have false cancer histories. It's pretty substantial. So you'll hear them talk about developing a pedigree. And so it helps us also look at how things may be inherited. If we see lots of cases, it makes us think of an autosomal dominant. There's times where I'll see some young age onset cancer in my clinic, and we think, well, this may be autosomal recessive. That's why we don't see a family history of it. Mom and dad each carried a copy, and it's a relatively rare occurrence. And so early age onset triggers also referrals for counseling. And this is just an example of a pedigree where they'll be drawing it to you, and at least in our program and most genetic counseling programs, they'll give you a copy of this so you can share it with family members if that's what you decide. And they usually fill in for cancer affected versus not, little notes on it. Square boxes are males, circles are females. This is our most famous pedigree for pancreatic cancer. So President Carter was touched with it with all three of his siblings and his father dying of pancreatic cancer. So I don't know if they ever have gone back now that we have all this more recently onset of doing genetic testing. I suspect that President Carter is not a carrier of whatever the genetic mutation is, or he had more peanuts or something that was a protective agent. I don't know, but thankfully he has not been affected. So why did my loved one or friend get pancreatic cancer? That's a great question. I'd like to simplify and just say bad luck, bad combination, but there are ways that these cancers develop. The bulk of them develop through what we call Panin lesions, which are progressive mutations occurring in these tumors that are acquired. I don't want to confuse people. This is why I try to do it. From the tumors themselves. As the cells replicate more and more, there's always a chance for mistakes. And when they make enough mistakes over many years, and the best estimates are that people with pancreatic cancer, when we try to make a guesstimate, will have had that cancer for a good at least 15 years in their body. But it's at a microscopic level where we can't detect it until the last year or two. There are some other cystic cancers, neoplasms, that may be precancerous, so not everyone that has a pancreatic cyst gets it. There's over 2 million cysts estimated in the United States. Autopsy data shows 30% of the population will have a little cyst in their pancreas. I've already told you, 30% of the population does not die of pancreatic cancer. So most of these cysts have nothing to do with cancer, and we work hard, our institution and others, about trying to sort out who is. And it's estimated that maybe about 15% of pancreatic cancers go through the cyst pathway. One of the reasons why I bring it up is that some of the things that we find on screening studies are cystic lesions, and that gives us sometimes a window to identify with it. And this just shows you that a lot of these have derived from that pancreatic duct that I showed you, and that the cancer cells can get more and more atypical in the duct, and it goes up the greater the Panin lesion. And Panin 3s are basically carcinoma in situ, so cancer's just growing there but hasn't spread or become invasive, and then it becomes invasive. And as that happens, with a lot of things that we know about molecular biology, we see associated mutations. Now, these mutations can be important information, and companies have come out, Foundation One and other companies, that are trying to use these informations then, because we know these cells have it, a good proponent of these. Problem is, not as these cells mutate, they lose some of these other mutations and gain others that we try to target the therapies for. And so some of you may have heard that terminology from those of you that are involved with oncologists. And that has to go with understanding these mutations. And this just is a schematic about the different cystic lesions. So can we screen for pancreatic cancer? Just everyone, like we do with mammography for breast cancer in women, colon cancer for everyone. And so let's be a little bit clear about what we're talking about. Screening means that we're applying a test in an asymptomatic general population. Surveillance means that we're applying this test to people that don't have symptoms, but they're in a high-risk group. And then a diagnostic is when someone comes in with a complaint, weight loss, abdominal pain, and you're doing the workup. So to make it a more easily extractable example, I'll use colon cancer, because many of you have had to undergo the colonoscopies. Colon cancer occurs now in about 5% of the population. It used to be 6%, but since we're removing polyps now, we're able to identify precursor lesions. We cannot identify these Panin lesions. They're molecular. That would be the precursor lesions. That's why we talk about them. People are working on molecular imaging, and actually I co-direct with my boss, Dr. David Wickham, Pancreas Fest. And we have international and national experts every year come to Pittsburgh in July, and we host them out at the University Club. This will be Pancreas Fest 2015. And the NIH is piggybacking onto our Pancreas Fest this year with an imaging one. What are the needs for the pancreas? So for both pancreatic cancer and pancreatitis. And so we have a national, international workshop being done the whole day We're trying to figure out ways of molecularly detecting these changes before you see them with the CT and the MRI, when the lesion has to be at least a centimeter, or which is a third of an inch, 2.54 centimeters per inch. That's if we're lucky. So people are working about it, and we are very pleased that Pittsburgh's able to at least host this meeting so that we could do it. The NIH actually likes hosting meetings in Pittsburgh because they do it about half of the cost that they do when they host these workshops in Washington, D.C. So it's one of the few examples that you can say the government is actually responsibly spending your money, I think, and actually looking at it. When I do colonoscopy, though, on someone who's bleeding, then I'm doing it on someone who has symptoms. That's not a stage that we want to get to with the pancreas. And what you're going to learn from my talk, just to give you the punchline right now to do it, is we don't screen for pancreatic cancer in the general population. And I'm going to show you why. What we're really talking about for this talk is surveillance. So even if you hear me misspeak and use the term screening, I'm not talking about doing the general population, just high-risk individuals. And that's what I'm going to spend the next part of this talk talking about. So remember, the goal of any successful screening program or surveillance program is to decrease the risk of dying from that cancer. So I tell my high-risk individuals with other cancers where I'm more confident about, like colon, that I may not prevent you from getting a colon cancer, but we are going to find it at a stage where we can cure you of the disease. That is a success. We don't want people to die of the disease. And so secondary goals, of course, are indolent cancers. And this complicates matters because those of us who carry the XY chromosome have to worry about prostate cancer. And there's a lot of press about overtreating now because you may get some cancers in your body that may never kill you. So we have to determine whether the cancers that we're talking about are indolent and will never kill you. And that may lead some of these cystic lesions, you may live with that cyst forever and not kill you. But if you undergo a pancreas surgery where in the wrong hands, in our hands, there's a 1 to 2% chance, often on very sick patients, of dying from the surgery. And you take a condition which may in the future have a 1 to 2% chance of turning into cancer, or 0% chance, as we may learn more. It seems you don't want to operate on that person and subject them to that risk. I don't think that, through these Panin lesions, if you get to Panin 3, I'm concerned. And if I knew about it and could reliably diagnose them, I would remove it. But the cystic lesions, I'm less aggressive about because I've seen them for so many years now and followed them. We also have to be careful because I could easily mislead you and not point out all the warts that I have, but we could have what's called lead-time bias, and I'll show you what I'm talking about, where it makes it look like I'm brilliant and see, you lived 5 or 6 years with this diagnosis where, I didn't make a difference, and I'll show you an example. And just as importantly is that if I give you a test and I find it at a stage where I can't do anything about it, I haven't necessarily done you a lot of favors, and I may have spent a lot of your money and put you through a lot of stress and risk. And so we have to try to find cancers where we at least can give people a chance. And so for me, I've set a lower target, and I'll show this again, of just finding people that can be resected and having that opportunity, because there's too many people with pancreatic cancer that don't at least have the opportunity even to be resected. And with our improvements in chemotherapy and our treatments and stuff, we can get the volume down. Maybe we can make this a more chronic disease. And you have to have a test that's acceptable to patients and PCPs. A lot of my patients don't like taking that colon prep. I don't understand that, but we don't fortunately have to do that with the screening technologies I'm talking about for pancreas. And so this is lead time bias. So say someone gets diagnosed with pancreatic cancer at the age of 65, and they die from it at the age of 67. So 2 years. Now let's say if I do a test on them and I diagnose them at 62, but they still die at 67. It looks like they lived 5 years with their disease, but they still died at the same age. It's really hard to sort that out, when you're talking a couple years. But I can guarantee you, if that person dies from an MI at 85, we had a successful screening test. So we have to be careful when we start looking at these small little changes of a year or two and determine what they died from and whether we really have just done lead time bias. and diagnosed it earlier, but have not impacted on the natural history of the disease. Indolent disease means that you may be diagnosed with P, but we'll call this prostate cancer instead, and 62, and you may die from an MI and never be died from that disease. And there's a lot of potential complications from being treated for prostate cancer, including sexual dysfunction, radiation proctitis, pain. So there's a lot of downside, urinary incontinence. So we have to be sure that we're certainly treating the right groups of patients with some of these diseases. So goals for pancreatic cancer in the short term is finding a tumor at an early stage. And so ideally with no nodes present, and I think that that's a good window. Long term, it's going to try to find those PANN3 lesions or those cysts that we know are about ready to or just have a little focus of cancer but haven't spread. This shows you right now where we're sitting at with our localized stage distribution, is that localized means it's just staying in the pancreas alone. Regional means that it involves the lymph nodes. So 35% of our patients approximately have local regional disease, where they have the opportunity to be resected. Some of those, unfortunately, it's geography. I didn't spend the time on and my surgical colleagues will tell you, is that there's some major blood vessels that are run by the pancreas. And if you get the bad luck of having one of those involved, it doesn't necessarily mean that it spread early. It's just a bad location for the tumor. So can we screen the general population? So even there's about a 12 per 100,000 age-adjusted incidence of pancreatic cancer. If I had a test that picked up every cancer and was only wrong 1 out of 100 times, and I applied that to the general population, I would detect all 12 pancreatic cancer cases, but I would have almost 1,000 people who I work up and evaluate that don't have cancer, do not have pancreatic cancer. So even though it seems like that's an incredible performance status, better than almost any test out there to date for any cancer, better than colonoscopy for colon cancer, because it's not a perfect test. We have a miss rate. So it's not feasible. We do too many workups for too many people. So that's why we have to look at who's candidate for surveillance, who's at high risk, where we get a higher prevalence rate of the disease and the risk. And in those cases, we'll have better outcomes in those tests that we talk about. If you can get 1 in 100 instead of 1 in 1,000, false positive, you start getting to better enrichment, so tenfold enrichment. So what do we know right now is, I told you hereditary is the biggest risk factor, and those are known genetic syndromes with a increased risk for developing pancreatic cancer, and I'll review those for you. And it's also having 2 or more cases of pancreatic cancer in the family, and that's what we call familial pancreatic cancer. Now, there are patients that if you just have a family history of pancreatic cancer, you do have a mild increased risk for getting pancreatic cancer. It probably transcribes to about less than double, similar to smoking, and it's not enough of an enrichment that we screen people for that. I'll show you some data on why we screen for more family members. And we've seen this in our own registry, where about 5% of our patients in our pancreatic cancer registry have a family member with pancreatic cancer. So there is an increased risk with it. Now, there's a variety of syndromes here. The one, Angela Jolie has familial basal ovarian cancer from BRCA mutations. This is the biggest risk. It's the 3rd most common cancer in BRCA1 or 2 carriers is pancreatic cancer. Lynch syndrome, MLH1, MSH2 is another common mutation. So what are the risks for these pancreatic cancer family members? So if you have these mutations, the risk varies. In the BRCA families, it's only doubles to maybe 9-fold increased risk, and we'll talk about how we incorporate that into our screening strategies. And with FAM, which is familial atypical multiple mole, that has to do with melanoma, that increases your risk to 13 to 39-fold. And then there's a variety of other syndromes. I just wanted to show you some of the genes. This is a pedigree where there's 7 family members that had pancreatic cancer in here. So this is no recognizable syndrome from the pedigree. And this is what we would call familial pancreatic cancer. And you can see if you have 3 or more first-degree relatives. Now, first-degree relative is someone who's directly connected to you, either a sibling, parent, or child. Your risk is 17-fold over the general population. If you have 2 first-degree relatives or 1 first-degree relative in a familial pancreatic cancer case, that means there's at least 2 of them, and you're directly related to at least one of the cases, your risk runs about 5 to 6-fold. So what's the rationale then for doing genetic risk assessment? You can provide a reason for someone's cancer diagnosis, and we may help provide information for that individual affected with pancreatic cancer that could guide therapy. If we find you to have a BRCA mutation, you may be a candidate for a PARP inhibitor. And it also addresses, and I think this is one of the main motivators for people, concerns about passing that risk to their family members. Now, what's the downside? There's no known benefit of knowing future associated cancer risk for pancreatic cancer, in terms of we don't have a proven surveillance strategy. But with some of these syndromes, there is proven strategies for screening them, and I'll show you why. So that's why we're with it. And you do have to deal with this issue of variants of unknown significance, where we give the family or the patient a lot of worry when they carry a mutation that we don't know has any clinical significance. So who are candidates for genetic referral? So what we do is we evaluate them, and we look for 3-generation pedigrees. This is what we push the doctors to do here. We're obviously very attuned at Pittsburgh because they know by group when we're available to see people. And so we look for an excess number of cancers just in general. And there are certain cancers that we look at that are associated with it, and I'll show you. We look at early age onset cancers that run in the family and lots of pancreatic cancer. And if you break it down, probably about 30 to 35% of cancers are from inheritable factors. The rest of them are what we would call sporadic. And of those inheritable factors, you could see that we 60% of them. Maybe I'm privy to a little bit more data from a new study that we participated in at Johns Hopkins. We gave them DNA in our familial pancreatic cancer patients, and maybe down to 76%. The couple, another 1 to 2%, we're getting little slivers of this pie. To be honest with you, that's the way it's going to be. Big genes are not going to be found nowadays. They've done enough studies that the low-hanging fruit is gone. And so these different mutations are accounting for the rest of the slice of the pie. And so here's the type of cancers that we'll be looking for. When you see melanoma, we think of FAM. If we see breast and ovary, we think of PALB2 or familial breast ovarian cancer. FAP is for colon. Lynch syndrome may be with colon. Some other rarer cancers may come along with some of these other mutations as well, including ataxia telangiectasia mutations, which may see breast or colon. And so here's a family that had a lot of melanoma and pancreatic cancer in it, and we found them to carry that CDK2N mutation. Here's a family which had pancreas, but a breast cancer in it. Now this breast cancer, this is what we often see, is from the wrong side of the family. If the pancreas risk is from the grandfather for this individual. But if you look over here, his aunt's daughter had breast cancer at the age of 36. That triggered us to look for BRCA mutations, and we found this person to be a BRCA mutation carrier. So that's why the genetic counselors look for clues. And it used to be that we didn't have the luxury to run a lot of panels, and I'll talk about those in a moment, where it's still important to do the clues because it helps guide whether or not we want to do the testing, but we have time. So we all obtain our personal history. You should use a genetic counselor. And what's really limited our use in the past was that unless patients met criteria for a known hereditary syndrome, we weren't able to get it paid for. There's costs involved with it. And we didn't have the tools to do it because Myriad Genetics, and it was a Supreme Court ruling in 2013, they had the patent on the BRCA1 and 2 genes. They were out and discovered it at the University of Utah. They spun it out to a company. And so about 10% of, for example, pancreatic cancer And those hereditary cases could be from BRCA. Well, that means that you had to send blood to them, get it tested, and insurance companies were not happy about it. Then you say, well, it was negative for that, so I want to test this gene with this company because they have the patent for it. And so we were going nowhere fast. Now, as soon as that Supreme Court ruling changed, so this is really something that's an evolving practice, because I'm talking 2013. So people that I counseled in 2012, 2011, 2010, we're revisiting. So we go through our pedigrees and see if we are able to make contact with people to let them know that we have some things available. And we're doing some testing to see. And the other thing that's changed is the advances in technology, and that's next generation sequencing. So I was talking to one of the individuals here, how it took a smart grad student saved us all by linking together a bunch of PCs on how to take all this genetic data that people were getting and put it together, to put the genome together. So he beat a company to the draw. And because of him, that prevented any of these issues of technology being patented. People can patent certain aspects of the technology, but the human genome was protected. And that was a key development. And now they've gotten that technology down, so instead of being $1 billion, like I said, it's $3,000. And it can be even cheaper depending on what mutation you're looking at and how many, to look at the whole human genome. But we don't look at the whole human genome with cancer testing. What we look at are panels of genes known to be associated with it, because if not, you end up dealing with a lot of these variants of unknown significance, and we don't know what the importance is, and we don't know what the risk is. So we may be counseling people to do things in cancer. For example, breast cancer, if the risk may only be double. So with some of these mutations, we don't tell people to go get the mastectomy like Angela Jolie did, or get your ovaries taken out. But if you have a big enough risk, like these BRCA mutations, where it's a 60-80% chance risk, it may be worthwhile to undergo such a drastic procedure, or to have your colon removed to lower your risk of colon cancer if you know you have 60 to 70% risk, as compared to 2 to 5% risk. So it's one of those trade-offs. So we have to have actionable items that we can use. So we've done about 18 patients. We're looking back at 30, 35, when I made the slide, but we're still looking at it for an abstract to come in here. And we got about 11% of our patients with a positive mutation in our experience of people that we're counseling. We're taking a little bit of different tack now, and have just using this technology, taken my pancreatic cancer patients who have a known secondary cancer, colon cancer or other cancers, and we've gotten, and not irrespective of what the rest of their family history is, and we're just getting the data back. We're working with one of the companies that is running this for us, the mutations for free, but we're looking at maybe a hit rate of as high as 25%. So I think in the near future here, as data from our site and other sites start coming out here, we're going to be expanding beyond the family history to personal history of people affected with pancreatic cancer. I know people are working on it, but I'm dying to do pancreas and breast. And so I'm working with, hopefully, we almost have all the data in for this one. I'm going to try to talk the company into doing it. They obviously would prefer us just to order it on the patients, but a lot of the insurance companies don't want to do it. And I want the answer now. And so we have a lot of people that unfortunately have passed away, but they participated in our research study. And they trusted us enough that we would find the technology to catch up to having the resource. And so I've been banking all of this stuff since I've been here at Pittsburgh for 8 years. And now we're starting to use it because we have enough numbers to go to the companies and say, we can answer this test for you if you just give us the dollars to do it. And they don't have to give us the dollars, just give us the technology. I don't charge them for sharing these resources. What's their benefit? They may be expanding their market. I don't care, because it's a service for my patient. They're going to have to use this service. So, so more and more companies are. It's ironic. I'm sending some DNA out to Myriad Genetics, who had the patent there with the Mayo Clinic project. We shared with Hopkins under a scientific reason when they're looking at this genetic panel. And Vitae Genetics is doing that Lynch syndrome, the colon one, where we're looking at Lynch-related tumors. So I think it's a good thing. I guess I should do that as a conflict. I do research with these companies, but don't own any stock in them, get no financial reward, but they do fund some of by providing free genetic testing. And maybe some of them will supplement some of our collection costs, but nothing else. So I guess that's a disclosure. So I'm not married to any of them in terms of any financial gains. I should point out, the other thing I didn't point out there is that 50% of almost 40% of our patients had these variants of unknown significance. So we had to spend the time counseling them, saying we don't know if this is real or not real. We put it in predictive modeling because these genes make proteins, and we try to see whether it'll affect the protein. So people may have computer models where they try to say, does this protein work or not work? And most of the time it says we think it works, and it's a benign substitution. So, but it's something that we have to deal with. And it's a risk for doing genetic testing. Oops. So I think to summarize genetic risk assessment, we could say that presently the possibility exists to identify candidates for genetic testing based on family history, and maybe based now as it expands on family and personal history. We don't know the role for early age onset pancreatic cancer patients. I know that that's another project that I'd like to do. I think some of our other centers are working on it as well, getting people to run these panels on younger age. And some of that data may be available from the Hopkins study, because I know some of the people were young aged onset, but that hasn't been completely reported yet. And we now have new guidelines that I was happy to be part of from the American College of Gastroenterology, which was the first guidelines for doing genetic testing on pancreatic cancer. We're hoping that will ease a little bit some of the pain and battle with the insurance companies, because they don't like to pay for it. It's just a cost. And there is an expanding role now for doing these tests for treatment. And I can't tell you how complex this is. Knowing what I know would take me all day to deal with all the companies. So having expertise, because I see a lot of people that get tested by their community doctors and they don't know how to deal with the answers, so they send them to see us in our hereditary program. And so sometimes we find out the inappropriate people have been tested. And I think that's why some of the insurance companies are starting to nix that and saying you need at least a trained genetic counselor before we send off this $3,000 test. I know it sounds self-serving. I'm the first to admit it. We always say send to an expert or send to this, but there is, I think, data to support that approach. So, summary on who should be screened. We don't screen the general population. We reserve those for the patients at the highest risk, and that's usually the hereditary risk factors that we talked about now. And sometimes people say, I've heard about diabetics. Diabetics are not enriched enough yet, but people are doing active research, because we know by the time you get diagnosed with pancreatic cancer that you either have some sort of impairment of glucose tolerance or frank diabetes that occurs, particularly within the first 3 years of diagnosis. Although diabetes itself, long-standing, is a slight risk factor, again, less than smoking, but that risk is not only 1 in 100 for newly diagnosed diabetics. And again, that's not a great enough enrichment of the population for us to get good performance of any tests that we have now to do screening. So how should patients undergo screening? Is there an easy blood test or imaging test? CA19-9 is a level that many of you are familiar with. It doesn't perform great. It has about an 85% sensitivity and an 81% specificity. So I showed you a test at a 99% specificity where there was 1,000 false positives. You're talking tens of thousands of false positives at a cutoff level of 37. So it's not a test that performs well. So it's why we don't use it to screen in the general population. Now, we may apply it to people that come in with symptoms, and we may apply it to monitor disease. That's a different story. And the higher you go up, the lower the sensitivity is, but it improves the specificity. And this was proven in a Korean population where they took 71,000 people that came to a GI clinic, and they used a cutoff of 37, and over 1,063 people had it, but their positive predictive value was less than 1%, so less than 1 out of every, so about 10 of their people had cancer. I think it was 11. So it was that had pancreatic cancer out of the 1,063. So it just doesn't work. So we have guidelines out there. It's not my job to show you it, but just to tell you that people have debated these issues of how we best screen it. The most recent one was Mimi Canto led the group out and published it in Gut. And hereditary syndromes are one that we go to look at. And so most people are in agreement to that. When we get to some of these like BRCA carriers or Lynch carriers where the risk isn't as great, maybe 2 or 3-fold, we usually limit our screening to those that have a pancreatic cancer expressed in the family. So you may be a BRCA carrier and you have a 1st or 2nd degree relative with pancreatic cancer. We'll test you. We have our own data that we're in the process of writing up that a BRCA carrier with a 1st degree relative has a 21-fold increased risk of getting pancreatic cancer compared to all BRCA2 carriers that have a 3-fold risk. So it seems to identify a subset of the group. And so there are some finessing that we do. Most of us go to endoscopic ultrasound. It's a strong bias of mine as well, because I think you pick up solid lesions the best. You may see cystic lesions a little bit better with MRI, but the ones that we miss are usually very small and probably not of any clinical significance. I told you 30% of the people have small little cysts on just random autopsies of the pancreas. The difficulty is you need an experienced endosonographer that's used to looking at the pancreas and not someone that just does it locally and doesn't have an experience, because we're really looking for small things. I'm going to give you an example of that. So even the consortium themselves can show you. So I have to always be honest that we have warts. We don't have consensus, because you have people that are very optimistic about stuff. You have some people that sit in the middle that I think try to look at the data. I think that's where the bulk of us are at. And then we have some people that are totally pessimistic. I'm not totally pessimistic about it. Dr. Henry Lynch, who was the one that got me into studying cancer genetics when we worked together, had this great slide that he showed me. He's sort of the grandfather or father of cancer genetics for counseling family members, and he has Lynch syndrome named after him with colorectal cancer. He has this great slide of having an ostrich with its head in the sand. And it's like, yeah, we could be like an ostrich and wait till everything's been figured out, or we could try to at least be proactive about it, recognizing with an honest discussion the limitations in the role of screening. So those of you that have dealt with my clinic in the past know I won't survey anybody's pancreas, not like a colonoscopy where I'll show up and have 3 of them on my schedule because their primary care physician did it, because I know there's data out there, it works. The general population's been educated. I don't know whether surveillance makes a difference. And so I will sit down and give an honest assessment and discussion with the patient, its family members, so that they're aware of the limitation. And there's no consensus on when to start. Some of them we use syndrome, some of them we use, when we have pancreatic cancer run in the family, 10 years younger than the age of onset, age of 50, if most of these fortunately are still older, risk. And we don't know whether the most important factor is whether it makes a difference, whether our surveillance makes a difference. And I'll show you a little bit the international findings. We do think that if you're going to do the operation, you should do it at an experienced center, because that does make a difference. Now remember, this is the consortium had 100% agreement on that because it was all self-serving. We didn't just take people off the street, surgeon off the street, and say, should you be doing it in your local hospital when we know you do it? These are all centers that benefit from having patients come to them where they're interested in studying the disease, so of course they're going to make that. But I think there is clearly data that high volume centers do have better outcome than low volume centers. And that's done through looking at just registries of pancreatic cancer resections. And we have to, at our center, and most of the centers are now adopting this as well, we have a multidisciplinary approach. We just don't take a finding that we find on screening or surveillance and take someone to the operating room. And we also review our patients with pancreatic cancer as well at a multidisciplinary clinic where we have radiologists, gastroenterologists, surgeons, radiation oncologists there, and pathologists. And we review any of our puzzling, not straightforward cases. If you look at about reported data, so it's not a lot. There's millions of people, multiple millions of people that have undergone colonoscopies. And we have plenty of data out there to show you that colonoscopies save lives. We don't have that. We have maybe 1,500, 2,000 high-risk individuals that have been reported. And you'll see anywhere from 4 to 9% of abnormalities when they've been surgically verified and what I consider something that the person benefited from having the surgery from. And, there may be a precancerous lesion found in up to 23% if you just use clinical diagnosis. Those usually pertaining to cystic lesions. But just as importantly, 30 to 40% of operations in the old days, particularly when we were operating cysts, were for benign lesions. And I had a patient that I had a small cyst in their lesion who, with a genetic syndrome, he'd already had a personal history of 3 cancers himself. And when I told him he had something in his pancreas, this is the downside. He underwent an operation, and it wasn't based on my advice. Fortunately, it was a distal pancreatectomy where it was a benign cystic lesion. But he just mentally could not live with it. So, I was sure he was done at our center and everything, but it wasn't, our consensus decision had been follow it if he could deal with it, but he just couldn't deal with it. And that's fine. Those times happen, but it's a risk-benefit ratio. But it's a downside for screening that we have to be aware of. So here's a case where actually this individual right here came to see me initially, and she told me that her sister, I was talking to her about surveillance, how we look for cystic lesions as well as solid lesions. She said, my sister here was told that she had a large cyst in her pancreas, and her doctor said, come back in a year for a scan. I said, wait a second. It's not you who I need to see. Yeah, I'll do screening on you because her mother and both of her aunts had died of pancreatic cancer. So there was 3 cases of pancreatic cancer. So she was convinced that all the women in her family were going to die of pancreatic cancer, and she had 2 other sisters. So she ended up having a tiny 2-millimeter cyst that hasn't changed now over 8 years. But her sister came to see me, and I saw a cyst that I thought was an IPMN, and it was about 2.5 centimeters to 3 centimeters. I knew her family history. Our criteria at that point in time in particular was to operate on it when they're greater than a couple centimeters, and we told her that. And her daughter lived in Chicago and wanted her to move back closer to home after a major surgery. Things got delayed for 6 months. I set her up to see an experienced surgeon there, and by the time they opened her up, her cancer had spread throughout her body. I didn't know she even had cancer. I thought it was a precancerous lesion. So this sister then came to see me, the 3rd sister. And I did a screening test on her. She has a cyst. I already knew what had happened to her one sister. I said, I don't want you to live with this cyst. But this cyst was about 1.5 centimeters, and it was sitting in the head of the pancreas. She said, you know what? I'm 78 years old. I do not want to have a major surgery unless you can tell me I have cancer. I said, that's fine then. I'm watching you closely. Your sister, I don't know if it was a cyst that turned into cancer or if it was elsewhere in the pancreas, because these cysts we still have to follow our patients. That's why we follow these patients with cysts, because they're at risk for not only developing cancer in the cyst itself, but it could be anywhere in the pancreas. There's a field effect. And so back then, we weren't as cognizant of the field effect, and so that with the sister. So I said, that's fine. And so I did her then, and the rest of her pancreas looked fine. And she came back like 3 months later, and she had the following right here. A little vague spot right by her splenic artery. And I said, this isn't good. This looks a little bit solid. And actually, you can see there, we have the capabilities under endoscopic ultrasound to stick a little needle into it. Got a few atypical cells. And I said, I'm a little bit nervous about this. We got to follow you closely. She said, unless it's cancer, I don't want to be operated on. And so we did an MRI scan, because I said, I can't sit here and follow you with an endoscopic ultrasound every 3 months. There's a risk involved with that. And you don't see anything. You can't see that little spot there. But I brought her back in September, and this nodule had grown a little bit, and now it showed cancer. And most importantly, it showed cancer in an area of her pancreas that we wouldn't have removed with the Whipple. She was smarter than I was. And this is where we really started getting, experience. And so I think in retrospect, her sister probably had a tiny little lesion, which I wasn't picking up, but over 6 months had increased in size. And it could have been near where it could have been in the resection margin potentially. It may not be, but it taught us a couple things. One, if we're going to operate on someone with a hereditary syndrome, we really push for the whole pancreas coming out because of this field effect. And two, that we're not always pushing for the cyst itself to do it, to remove it because of the cyst itself. Because when we looked under the microscope, her cyst itself was a low-grade cyst. It had nothing that we would have considered it a failure if we had operated on her, because it wasn't at that stage where it was turning into cancer. So we would have subjected her to a major surgery. Now she's diabetic, but she's out 4 years, and except for dealing with brittle diabetes with an insulin pump, she's had no signs of her cancer coming back. Now, does that mean we made a difference? No, we don't know. But I like to think that at least we got her the opportunity, and I have her sister's case where it was conversely, where we didn't act on it promptly. So I think the important thing is that you have to recognize that we find things that we don't want, that we may operate on and subject people to risk for it. But I think that we are finding some people that we can make a difference on. And so our own experience here is that about 80% of our patients are able to be at least, that we have sent to surgery for a cancer, that's 4 out of 5, have had a tumor that could at least be resected. Now, not all of them were cured of it. That's the problem. And if you look at internationally, several of the people that have been in active surveillance programs, and in some programs as high as 50% of them, were found at the time that they found their pancreatic cancer to already have metastatic disease. So not all of them were aggressive with endoscopic ultrasounds, though, and some of them use like MRI scans. And I think there's a little bit of a difference. And I think some of it also comes down to the types of scopes they use, and there's some nuances. So I'm not as much of a pessimist about that, just having had the opportunity to review a lot of these papers and critically analyze them. But I think it brings up an important point that goes down to what I said. We have to be sure that we're finding these things for it to be a successful screening test at a point where we could do something about it. The one patient that I didn't find was the patient I told you about, that sister. And I don't know if it's the delay that made the difference or not, but I'm taking that as I wasn't successful. Because if she'd been operated on here and we'd opened her up, we were going to, have her whole pancreas go. So we favor endoscopic ultrasound based on being able to find these small little lesions, which I showed you are an MRI. That's anecdotal. It's personal experience and bias, but I talking to many of my other colleagues as well. I could tell you that this is a hot issue here. The GI meetings are next, I believe, Friday for them. I have a meeting on Saturday with an international consortium where we're all starting to put in a database our experience with our resections for pancreatic cancer, so that we have the ability to fill in this data for these individuals to get a better handle and track how good we are. I know that I'm a lot better now and a lot more aware of this stuff than I was 6 or 7 years ago. I didn't used to think I was that bad 6 or 7 years ago, but we've learned a lot about these cystic lesions. Guidelines have changed for pancreatic cystic lesions. We used to just go by any cyst that was greater than 3 centimeters. We used to operate on them, but only about 10 to 15% of those patients benefited from the operation. And so we stopped doing that outside of the hereditary setting. This is in a lower risk group. So then they revised the guidelines, and we're constantly revising those guidelines, trying to figure out ways of better diagnosing it. And it just brings up the importance of a multidisciplinary approach. So I always like to throw a little bit of a prevention again. Avoid smoking, eat a healthy diet with fruits and vegetables. I still push vitamin D, even though I can't always guarantee it'll help with pancreatic cancer, but it will help with a lot of other tumors. It does not help with cardiovascular disease. Weight reduction, if necessary. Obesity is a risk factor. And the people who benefit the most for exercise are actually people who are overweight. And a baby aspirin a day may keep pancreatic cancer away. So what's my personal approach for high-risk individuals? I counsel them about the limitations of surveillance. I do not offer prophylactic pancreatectomies. I make a person brittle diabetic. I know being a brittle diabetic shortens your lifespan. So unless I could show you data that that person was going to get cancer at a high enough prevalence rate, they may die, a 1 to 2% chance of dying. That has been reported in the literature. A hereditary family undergoing a prophylactic pancreatectomy with no cancer in their pancreas, ending up dying from the surgery at a different institution. very experienced institution, but it happens. When to start, we personalize it. When we have abnormal studies, I don't make the decision alone. It's an important decision. We discuss it amongst a group. And then we get, most importantly, people to participate in research studies. I don't personally care if University of Pittsburgh is the person who makes that discovery, but if our resources could be used for the field, to me, that's enough satisfaction. And I think that the University of Pittsburgh, I'm proud to say, is probably on at least 20 to 25% of papers that are out there with biomarkers for pancreatic cancer, just because we're very collegial with sharing of our specimens. So that's something I am proud of. And now we are participating with Hopkins and other groups here in a screening study for trying to improve this by giving secretin to our patients who are trying to collect some pancreatic juice. And so with that, whenever in doubt, when we talk about hereditary stuff, it's always important. You can always blame your parents, just like my kids did. So, all right. With that, I open it up for any questions or anything. Yeah.
Is that what you do? Is just pancreatic cancer?
In my practice? No, I do general GI as well, but I see the hereditary pancreatic cancer, but my colleagues do. I'm lucky here. One of the reasons why I left Chicago, where I was affiliated with Northwestern, at one of their hospitals, was because here we have a big pancreas program. So a lot of my colleagues who do endoscopic ultrasound and care for the patients with pancreatic cancer, we all use a common protocol. And so do the surgeons. The surgeons, we all enroll. This is what's so unusual about Pittsburgh, because I have colleagues at MD Anderson that have to come to me to get specimens, or Johns Hopkins. They come to us to get specimens because the surgery department doesn't work with the oncology department. It doesn't work well with the GI department. At least at the University of Pittsburgh, we've become very multidisciplinary and very sharing. And so everyone uses the common protocol. Now, there may be research study protocols additional protocols that people are on, but for our one that will allow us to share specimens and bank specimens are all used. So I have a bunch of colleagues that do it. If they have a hereditary component or concerns about the hereditary component, I'm the one that people would send them to, because I have genetic counselors that work with me in the clinic.
I know you're the doctor, and because of the speech, I'm going to stay awake all night because my head's going to be thinking. So I appreciate that. I really enjoy those things. But I know that you're the physician and you have training. But I'm also a mom. And I know that in a nutshell, mother, aunt, uncle passed away from double breast cancer. Not the only person in the situation of this, but I don't know what it was. He has pancreatic cancer. Now it's back in his liver. He's getting it ablated or something next week. Our son is being studied at the Mayo, Dr. Coolidge, with a rare form of cholangiocarcinoma with dysplasia, one of 7 patients that the Mayo in Minnesota has ever seen. Dr. Sung's on it. He wants to learn all about it.
Yeah.
But as a mom, I know there's something.
Oh,
I know there is.
yeah, that's exactly right. So, and that's the point. I 100% agree with you. But until we have the knowledge of finding out what it is, they'll counsel, they'll test the families, both sides, because the breast cancers was on your side of the family, right? So, you have to keep it. So the people that you want to test, now you would be obviously eligible for genetic testing if someone in your family didn't get it, because there's guidelines for breast cancer screening. But right. But the point is that this is where it comes back to that inheritance. This is the educating people. This is the hardest part to get people through, that you have to get as close as you can to being an informative individual, because it may be fine for you, but if one of your kids tests negative, that doesn't mean your family doesn't carry that risk. If you test negative for it, and there's a mutation in the family, that means none of your kids carry that risk. And it also reflects nieces and nephews or, grandparents, depending on how the family tree goes up. The higher you can get up to an affected individual, the more information it supplies for the whole family and tree. So that's why that's why the genetic counselors do so much effort in trying to be sure that the right person is tested and educating them. So the attitude that I'm older, it doesn't matter is wrong. Because these cancers can occur. It doesn't mean just because someone else had early age onset cancer, someone else could have cancer and still be at risk and and they may never get cancer. These don't have 100% expression. And I mean, I'm thankful those people don't get cancer, but we don't quite understand, why maybe environmental hits superimposed on their genetic background, because it takes multiple hits to go down the line. So it's testing the right individual. Yeah.
My sister died of pancreatic cancer 9 years ago. I have it. I'm negative for the BRCA1 and 2. What's your recommendation for her two sons who are middle 40s to 50s?
So, two things. One, when did you get your genetic testing done?
October.
Did they test for a whole panel or did they just do the BRCA? See, I think that you should get a whole panel testing now because that's available. Because familial pancreatic cancer, there's a 10% chance. That would be the first step because that would be the favor you would be doing for them. Because if they are able to identify a mutation, that allows us to personalize who needs to get screened in the family. And we could give you a better defined risk. And it may be other cancers besides pancreas, ones that we have more solid data on. But if you tested negative, so that's valuable information that you could provide to your family. So whoever did your genetic assessment initially, you may want to revisit with them about that, about getting a full panel. If you're not able to get any informative information, I would recommend that. What was the youngest age of cancer, pancreatic cancer in the family? Pancreatic cancer, yeah. 60. So starting at the age of 50, any children, nieces, nephews should be screened because you guys meet criteria for familial pancreatic cancer. So expert opinion would consider you candidates for surveillance, and that should be done at centers that are experienced and know how to deal with these patients. Our people see the genetic counselors, but we wouldn't do genetic testing on them unless they were affected with some other cancer type, because you don't know how to factor in the results. Now, it may be that as the field expands and we learn more and more and we get more experience with this, that there's going to be subsets of unaffected people that we are going to be testing. So this is holding true right now in 2015 for several reasons. One, insurance companies won't pay for it. And so for a lot of people, that's an issue. And secondly, we don't have enough data. But if you start looking at where there's a strong advocacy group for, and I'm not downplaying it at all, but breast cancer and BRCA, and if you're just a relative and you have ovarian cancer in the family, a first degree relative, and you're not affected, they will test women for that unaffected. And you're getting rates that are just like a couple % chance of being correct. But there's a strong advocacy movement for it, and there's things that you can do. I'm the first to admit it if you carry it, there's a cost involved with that as well to society in terms of resources. Pancreatic cancer isn't at that point yet. It will get to that point someday when we can identify patterns of cancers an individual has without a family history, or family histories where we can at least say, as this panel improves and we get from, instead of being just 20% of known genes, we get it to 70, 80% known genes, then you may, someone smarter than myself will do the modeling to figure out what that cutoff should be. We're going to be able to start testing unaffected individuals. But right now, it's very difficult.
So you would recommend genetic testing before any kind of endoscopic ultrasound?
For you. for her sons, I wouldn't recommend genetic testing unless they based on their family personal history. I would recommend them being seen at a center that deals with pancreatic cancer surveillance to talk about surveillance. But the people we do surveillance on, many of them that come from family members where we don't know the gene, we don't do genetic testing on them. We just do screening or surveillance. So they're candidates for surveillance without knowing their personal histories of cancer and stuff like that. They're not necessarily candidates for genetic testing. But your genetic testing could be expanded. And if you had something that was found, they would be a candidate for being tested for that. And that would be potentially that's what put the family at risk.
How about if you're adopted? Like Kenny's adopted, when
Yeah.
my son's father is adopted, he's had throat cancer, and now they're pregnant. So it's like,
Yeah.
what happens then?
It's so I think the first improvement will be is if there's multiple histories of cancer in that individual, then you have a chance of getting genetic tested. It varies from insurance policy to insurance policy. I think you factor in age, other risk factors such as smoking, and you can always try. People will tell you the price, but the one thing about most of these commercial laboratories, at least the bigger ones, the ones that our group deals with, and most genetic counselors probably would as well, they'll give the people the price. If it's over $100 out of your pocket, they will contact you, so people will know how much it will cost to undergo genetic testing, because it's a real issue. I mean, in terms of the costs involved with these things here. So we always have to deal with that issue of adopted. And I always also deal with kidding around with my counselors when we don't see the family history. I always say, must be false paternity, in terms of what's causing the risk. But because there has to be a family history, but it's usually because autosomal recessive or something, But those are the issues that we deal with. And so 5 years from now, it may be different. Again, because these tests will also fall in price. As they fall in price, and we can get things to be used. And what I think is going to start happening with colon cancer first, and potentially breast cancer, and could even happen with pancreas cancer, is we talked about those targeted therapies. And so if you can take an affected individual with cancer and test them, screen them quickly for their germline to see whether they have these mutations, if the technology is low enough, they may help guide their therapy. Right now, we're taking the tumor and doing that, and for good reason, because a lot of these mutations are not present in the germline. But if we can get the cost low enough, we may be able to do both. And then, everyone will be screened to see whether there's something that's inheritable. But we'll be dealing with a lot of variants of unknown significance, and still a lot of situations where we don't identify with it. So we have to be careful for what we wish for in the screening field, because we can make a lot of people anxious about it.
I apologize for being ignorant, and it's not political, but the Affordable Care Act did away with not covering for pre-existing conditions. Did all of the other insurance companies do that?
Yes.
Yeah, right, so they don't cover that, but it's policy to policy what genetic testing will cost. They cannot discriminate against someone for health insurance. So GINA prevents health insurance. It doesn't mean life insurance. It doesn't mean disability insurance. But it does mean for they say you had like Angela Jolie. She can't be discriminated on for being a BRCA carrier. But it doesn't mean that her insurance company will cover the genetic testing for that. That's insurance policy to insurance policy.
But really, to be honest, part of my job is to read coverage policy bulletins for the insurance company. And I was just reading some of them yesterday, and I was reading minutes. I see them making strides. And I can see, although I can't discuss, what they're moving towards. And I think that we're at a point now where they're learning that by being proactive instead of reactive, their costs come down.
Right. But I could tell you there's some of the healthcare plans that we deal with, because my genetic counselors, we're appealing, we're constantly battling. And it's because they revisit guidelines and they revisit things every 2, 3, 4, 5 years. This is a field that's constantly in flux. The NCCN, the National Cancer Cooperative Network, they have guidelines for genetic testing. They just updated their breast cancer guidelines. It now includes pancreatic cancer in it. That if you have breast cancer and a history of pancreatic cancer or something like that. Most insurance companies will be slow to adopt that, depending on how they're geared. It's and you sit there and you argue with them and say, and I get on the phone with these people and they say, well, you need to appeal it. And they have, it's almost like out of a John Grisham novel. It really is the stuff that we deal with here. I get phone calls where they send me a fax, and if the fax was like on a Thursday or something, and my genetic counselor, goes through the office here, and we don't get forward to it till like a day later, it's like, you didn't respond within 48 hours. Well, I didn't see it till then. No, you're not allowed to do the appeal now. The patient has to do the appeal. It's like, it didn't even come to me because, the company got declined. The commercial laboratory gets declined. They wait a day to notify us. They send it at 4 o'clock. Someone didn't take it off the fax machine, or I'm not even back in the office. I'm somewhere else. And it's ridiculous. The federal government, that's a lot of the federal government's policies. And the other thing is that they get you on is that I'll talk to these people that I'm supposed. I 10 minutes to track them down. I spend 5 to 10 minutes discussing the case with them. They say, well, it sounds great, but I don't have the power to change our guidelines in the way it's written in this book. And I say, then why the heck do I sit there and spend my time on the phone with you if you aren't going to take what I say to you and say, here's the updated guidelines to do it? Sorry, the patient has to appeal. And most of the patients don't have the know-how or the desire or the energy. A lot of them are sick to do this. And so it really is a way for them to get out of the work. And I hate to say that because I know I'm tainted because I see the bad. There's a lot of good that a lot of these insurance companies are going to do it like that. We try. We try. Yeah, but that's the people that have to do it right. You have, it's just tough. It varies from insurance company. And then sometimes people's insurance companies are written so they don't cover genetic testing and they can't afford it. So these are the ones where it is. So, I mean, we play games too because we know which laboratories will start running the tests and then they'll just say, well, we'll just bill whatever up to the 100, whatever the cutoff value that it is. So we play the game too. So there's sometimes reasons why we select certain laboratories over the others because some of them are more lax in terms of their insurance checks than others and that they'll guarantee to do the stuff. So there's a game that's played in. And I don't play it that well. I guess it's a Game of Thrones or whatever. So, yeah.
You mentioned targeted therapy. Can you expand upon that? What is it?
Okay.
What needs to happen?
Right. So what we mean by targeted therapy is when oncologists in particular, since that's the main one, but it could be for any disease, selects a therapy based on knowledge about the disease or the cancer. In this case, cancer, we're going to talk about pancreatic cancer. And so we know that certain drugs may have, when we test it on 100 patients, may work in 1 or 2 patients and be miraculous responses. And sometimes they go back and look at it and says, if they carry this particular mutation, the drug works. If they carry this particular mutation, the drug doesn't work. And they found this out in some of the antibody therapies with P53 mutations or KRAS mutations. If you're wild type, cetuximab doesn't work for colon cancer, and they found it at first in lung, and then they extrapolated it to other tumor types. And what it does is twofold. One, it avoids an expensive therapy in a patient that wasn't going to work, and 2, it allows you to maybe select a therapy that may work better for an individual and not better for another. So it's using the knowledge of it. And so the NCI and groups are getting together various chemotherapy agents that may work well with people that have certain mutations. And then there's trials that are being done around the country. So the people at least have the opportunity. So PanCan now will cover genetic testing on tumors for anyone with metastatic disease at no cost to the patient to help them guide their therapy and treatments. And so that's what we mean by personalized. Hopefully that answered. All right. Well, thank you for the opportunity to speak. Oh, sorry. Right. So when the people have no mutations, then there is the out-of-pocket cost, even if their insurance company, which is amazing to me. Why? When you look at it from a societal standpoint, I've had to battle with insurance companies because they'll sit there and say, this person's 80 years old, they had colon cancer, we have suspicion on, they do universal testing out of the tumors to see whether they have Lynch syndrome, and they'll say, well, it's not going to change what you're going to do for this individual. You're still going to do colonoscopies every year. And I said, he has 3 kids. He has 2 siblings, a bunch of nieces and nephews. If I identify the mutation in him, I spare all these other people undergoing, we can localize and personalize what it is. Well, that doesn't affect us, our insurance company. Our insurance company is only responsible for that person. So that's one situation where you have to identify the gene. Now, we're in a better situation if we know the gene responsible in the family. If you know the gene that's responsible in the family, out of pocket, that's called single site testing. And when you do single site testing, you don't have to shotgun approach. We just look for that one mutation. The cost falls dramatically. The cost falls to, in most cases, under $300. So I always tell families, you guys go to concerts nowadays. And I know my research coordinator went to Console yesterday, and they can afford $100 to go to a concert. You guys can make it a holiday gift and chip in and do it. This is valuable information to do it. So I think there's a difference with single site testing than the big test results. For surveillance studies, those still aren't always covered with insurance companies. I learned long ago, I don't lie and say, well, you have pain or you have this, because that covers you 1 year. We have to cover these people every year. So I always am upfront, and say, for family history. And we now have some pseudo guidelines and expert opinion that we use. We write a letter and we battle them. And sometimes, most of the time right now, it's covered. There's some grumblings that it may not be as we learn more and more. That's all the more reason for us to work hard to get a genetic etiology so that we can prove risk. But it's tough. That's why I think just ordering haphazardly, some of the things that hurt us is when people go ordering CT scans on patients because their family member died of pancreatic cancer. CT scanning has never been shown to be beneficial in the screening setting. And you're probably increasing the person's risk by doing annual CT scans because radiation to the area there. So it's people that's why expert opinion says come to at least talk to people that know the field, because it's still relatively uncommon to have the hereditary, or the familial pancreatic cancer patients. So that's one of the reasons why we push so hard, like your case, to when we have someone who's alive, who's informative from a genetic standpoint, to find out that information, because it can provide information for the rest of the family and potentially treatment. So in our clinic, everyone's flagged. And as we learn more and more, like I told you with the subsets of pancreatic cancer patients that have some of these other related tumors, we're going to, as soon as we can get this study out as quickly as possible here, we're going to be flagging those patients as well to get them to come see us in the genetic, testing or assessment, genetic risk assessment. I won't ever say it's testing because that's the decision you guys make in conjunction with the genetic counselor if it's appropriate. Sometimes it takes me longer to talk people out of genetic testing than it does just to do the genetic testing. But, I have to do what's right. Just give them the pros and cons. Did that touch on it well enough for you? Okay, good. All right, anything else? Good. All right, well, I guess if people, most of the people have our contact, I'm on the website, contact information, I have a few cards. My genetic counselor, I could tell she was distracted today because I asked her, I was downstairs and I said, I need pamphlets for our clinic. And she was leaving on a trip to go to a wedding in Charleston, and I don't think she was thinking much of it. I stuck it in my bag without even looking, and I came to take it out. It's like a hereditary colorectal cancer. It's like she gave me the wrong pamphlets. So I didn't want to bring it out here because I didn't want to. Pancreas cancer's already hit hard enough. Yeah.
I had your pancreas test last summer.
Yeah.
And I have the information. You said to me, if people here can pass it out, that's still to do it.
Anybody, always free to send out my information. Even if they just have a question, I respond to emails and everything else. I have some cards here that I'll leave on the table here that, that have my email and office number if people need them. I know many people do.
Is there any issue between now, between Highmark and the
Highmark has genetic counseling services. They have surveillance. Everyone has their own bias. Pittsburgh, the University of Pittsburgh side of things when it comes to pancreatic cancer. I can't say this for everything, Dr. Zay, Zurakat, Sung, we see so much more than they do. I mean, we see through the UPMC system over 400 pancreatic cancer cases a year. I showed you there was 49,000, so we see almost 1% of pancreatic cancer through our system here. And so volume alone, our surgeons are constantly doing these things. And so that often the cancer diagnosis and just having that relationship, the continuity decree has helped a lot. We're usually able to do it, but, we'll give guidelines. I have had some of my patients. So my patients that have had contact with me before the Highmark, they're okay. The future ones, we give them the names of the endosonographers. They're good guys, but they don't have research protocols. They aren't in tune with it. It just depends on what you're looking for, because I don't think surveillance is where we want it either. But I'm biased. Again, that's why I was trying to be upfront about it. We're self-serving because we tell you to come to the expert centers, and I'm at an expert center. No, so they get screened, and if they can, there's certain Highmark policies now that we can't take, and there's going to be some in the future that we can't take. I keep hoping that it'll get taken care of, and I don't have to worry about it. I just don't look at the insurance policies of my patients. That's a good and a bad thing, because as physicians now, because everyone has skin in the game, as you all know, with your deductibles and everything and these Cadillac policies, the bottom line is, as a physician, we need to know what the costs are, because when I'm making these recommendations to you, there's an out-of-pocket cost. So forget about just whether it's a good enough reason to do it. And that's something I can't make that decision for you, whether or not that cost is worth it to you. But, if I sit there and tell you this is, I don't want people under the impression I have to have the scan or I'm going to die of pancreatic cancer. Even with these hereditary syndromes, and we're giving you these risks, even if your niece and your nephew that you're talking about, their risk is maybe 10% lifetime risk of getting pancreatic cancer. So the odds are they will not get pancreatic cancer. But we all know how challenging it is when you get pancreatic cancer. So we have a different point of view. And so I'm proactive on it. Don't get me wrong. I don't downplay that risk. But is that worth them coming in and spending $1,000 out? I don't know what. I'm just making up that number. I don't know. It varies from person. A year for something that I don't know will even make a difference, or may diagnose their pancreatic cancer at a later age. So they at least need to be informed about that decision. Exactly. And what we know now, and like I said,
If you're not into it, working towards knowing.
right. But so that's where it becomes self-serving then. Then I would argue with you, if you go to a community gastroenterologist who isn't studying it, is his knowledge being shared? Is he sharing specimens? Is it being done there? So if you're going to be in a situation like this, that's different than I fully support. I see a lot of hereditary patients from community GI docs for colonoscopy and colon cancer, that's perfectly capable of being done out in the general population. I don't tell these patients to stay with me and do their colonoscopies when I see them. I provide the information because I have the resources available and the expertise, and then we send them back with recommendations for their doctors to do it. I do not send recommendations for most doctors to do it. I may tell people where family members are to guide them to go different other parts of the country where I know there's capable people doing this screening and surveillance. But it's not like a colonoscopy where I can just say, go ask, I'm moving to Wichita, Kansas. Where should I find a good GI doc that can do endoscopic ultrasound on me to screen me for my pancreatic cancer? I'd say, no, you need to go to someplace different to get it done. But I wouldn't do it in Wichita. But if they said I need someone to follow my family history of colon cancer, that's fine. Just there's a list of gastroenterologists that are board certified. Okay. All right. Well, thank you.